Dear participants, my name is Dr. Julia Zając, and I have a pleasure to welcome you at another EuroBloodNet Thursday webinar. If you have any questions during the presentation or maybe afterwards as well, please write them in the chat. And please welcome with me Professor Uwe Platzbecker, who will present for us today a webinar on the treatment of anemia of low-risk myelodysplastic syndrome. A few words about Professor Platzbecker. Is the director of the Medical Clinic of Hematology and Cell Therapy at the University Hospital in Leipzig. He is also a member of the International MDS Foundation's Medical and Scientific Advisory Board, chairman of the European Myelodysplastic Syndromes Cooperative Group by the ELN, and chairman EAJ MDS Working Party. He's also a board member of the SAL at the German MDS Study Group and Transcampus Professor of Hematology at the Faculty of Life Science and Medicine at King's College London. He's also a section editor at Leukemia Journal and member of editorial board of Journal of Clinical Oncology. Professor Platzbecker, the microphone is yours.
Thank you very much. The topic of the presentation was considered to be low-risk MDS. I have extended it a little bit also, and will cover also some high-risk MDS features. So therefore, the topic of my presentation, I call it patient stratification in MDS, and I will, of course, cover primarily what is new and very novel in the low-risk segment, but I think there's also a lot of things are going on in the high-risk compartment. So I thought this may be also appealing for the audience. So this is my potential conflicts of interest, and these are the learning objectives. Understand the current classification and stratification in MDS, also insights into novel biomarkers of prognosis and therapy, and understand the potential treatment strategies which are of course based primarily on classification and prognostication in MDS patients. So of course MDS is a disease of the elderly, which comes, of course, with some comorbidities. And of course, we have to see the MDS patient as a holistic approach covering several, or integrating several individual risk factors in patient stratification, which, of course, are disease-related in the majority of the cases, but may also cover comorbidities, cognitive functions, age, sarcopenia, which contribute a lot to the personal complaints of these patients and the quality of life. That's how we classify patients in a very robust way, and we have done this now for more than a decade to go for the IPSS. Sorry, there's a little change here in the slide, but I hope you can see what I mean. IPSS is a simple tool to predict outcome of patients being untreated, so supportive care only, and the median survival of the low intermediate one cohort is ranging from 3.5 to 5.7 years. And therefore, since the prognosis is that good, although it's of course dismal compared to healthy individuals, we call this subgroup of patients lower risk, and patients with INTO and high we call higher risk MDS patients. The IPSSR integrates 5 prognostic variables, including a very complex cytogenetic subgroups. And we now have also 5 prognostic groups. Very low, low are definitely low risk. High and very high are definitely high risk. The intermediate box is a kind of mishmash of different subgroups of patients, and I think it's sometimes not easy to integrate or to basically make treatment decisions in these patients. And I will come to this in a second, and will present you also some real cases. So lower risk patients are very heterogeneous, but also the largest group of MDS patients. Life expectancy mostly can be counted in years with best supportive care only. And the traditional goal with regards to treatment approaches is to improve quality of life, to basically keep the patient away from the doctor, less transfusions, basically. I think a curative approach, which is aimed in many high-risk patients, is not the primary goal of these approaches in the lower risk segment. However, we are now challenged by emerging molecular data, and of course, this information is sometimes puzzling because it pushes some of these conventionally low-risk patients into a high-risk box, and therefore, we are sometimes puzzled also whether we should treat some of these patients in a more intensive way. Mutations do matter, and they do matter not only with regards to the quality, but also with regards to the quantity. You see, the more driver mutations a patient has, the higher is the probability of leukemic progression. So this is, of course, depicted here in this figure, and makes things sometimes complex in a conventional low-risk MDS patient. So that's the way we use the current classification in low-risk and high-risk MDS patients. I just highlighted the introduction of a mutation, not only of a cytogenetic abnormality like del(5q), but of a mutation, so-called SF3B1 mutation, into this WHO classification. You see that patients with ring sideroblastic phenotype are a distinct subgroup of patients, because the presence of ring sideroblasts is of prognostic importance. And also patients can be classified based on the single presence of an SF3B1 mutation. And this is because patients with a ring sideroblastic phenotype and an SF3B1 mutation have a very, very good prognosis. So how to approach patients in the era of NGS-based technology, which are now available to many of us, but do we really need those NGS technology for the daily practice in a patient where I would say you have a confirmed MDS, so morphology, histology, cytogenetics basically confirm MDS. You are absolutely sure this is an MDS patient, and now you do the IPSS, IPSSR, you have a low risk and high risk category. So in the low risk segment, in case of predominant anemia and ring sideroblastic phenotype in the bone marrow, I think also according to WHO, you should perform an SF3B1 mutation analysis. And this is because these patients have very good prognosis, although they are heavily transfusion dependent sometimes. And because of the rather good prognosis, no transplant or no intensive strategy should be applied, and luspatercept, I will come to this in a second, may be a good second-line treatment option. 5q patients are treated very often with lenalidomide in case of transfusion dependency. P53 mutation, however, can be observed in 10 to 15% of the patients and confer a higher disease progression rate, and also treatment resistance also to lenalidomide. So this is important to know for more intensive surveillance strategy and potential early allotransplant option in the patient with emerging P53 mutations. Then sometimes you have patients with a mismatch of pancytopenia and but still in the low risk box. I think here also targeted sequencing with high risk features, I think, is important sometimes to delineate, let's say, the molecular high-risk genotype, which I think would make this patient eligible also for HMA-based treatment or even transplant. In a high-risk patient, I think P53 is also important in case of complex cytogenetics, and this is because patients with a complex karyotype without a P53 mutation have a rather, I wouldn't say good, but a better prognosis. And so you may even do a watch and wait strategy in some of these patients. And of course, AML defining mutations like NPM1, I think are also important to do in patients with basically AML and in the transition phase from EB2 maybe to AML. So this is actually the first description of the ring sideroblastic phenotype patients, and I just want to cite a very old publication, but still very interesting to read. So some workers restrict the use of the term sideroblastic anemia to those cases of anemia with high serum iron, hyperplastic bone marrow with erythroblastic preponderance, and increased numbers of ring-formed sideroblasts. Well, the attempt to identify this disorder on the basis of a single morphological feature is a wise one, is to be questioned. So this, I think, is maybe the birth of ring sideroblastic MDS, although as you can see here, it was questioned whether this is a single entity and a specific entity. I think now we know it is, and I will show you a slide.
Oh God, this is too fucking hard.
I will actually show you now two cases which I thought may be quite appealing also to the audience and quite interesting to share, because it's I think it reflects a little bit how emerging molecular data may also change our approaches in these patients. So let's say case 1 and case 2 both have predominant anemia. You see also red blood cell transfusion dependence. They have less than 5% blast in the bone marrow. They have trisomy 19 as a genetic abnormality. And in case 1, there's the SF31 mutation together with TET2 and DNMT3A. And then the other one has an UE2AF1, so also spliceosome mutation. But on top of this, also ASXL1 and ETV6. So if you go for morphology, MDS-RS SLD. If you go for IPSS, it's intermediate 1. If you go for IPSSR, it's intermediate. So both patients could be considered to be intermediate risk, and so rather, according to the new considerations, rather higher risk based on their prognosis by IPSSR. However, now we know that patients with an SF31 mutation and less than 5% blast have a very good prognosis, although some of them are really highly transfusion dependent for red blood cells. But you see, this is the leukemic evolution rate, which is the same actually in either way, whether you have unilineage or multilineage dysplasia. So these patients are around for a long time in the outpatient department, and they are sometimes heavily transfusion dependent, but the presence of an SF31 mutation translates into a rather good outcome of these patients. Do we treat these patients the same way based on ring sideroblast or non-ring sideroblast or mutation? Well, at the moment we don't make our treatment decision dependent. This is low-risk MDS, thrombocytopenia. I will not cover this in this presentation. Anemia and del(5q, I think I covered already. Revlimid is, I think, the backbone of treatment. But the majority of the patients are those with anemia and in non-del(5q, where according to the Epo-based model, Epo is or ESA are the first-line treatment. And actually, in case of failure, we have nothing to offer at the moment, and apart at least from clinical trials. But there is some recent advances, and I will actually come to this in a second. So what about Epo and ESA treatment. This is taken from the registration trial with Epo alpha. You see response rates here for the entire 24-week treatment period was 45%. So not bad, but actually also maybe less than expected, and only patients with an Epo level of less than 200 responded. This is for the darbepoetin, 34.7% response rate in the open label, where the dose was 500 microgram every 2 weeks. So also less than 50% response rate. What about reality versus clinical trial? This is taken from a large retrospective European study. You see that 61.5% responded, so much higher than in the registration trials, and the median duration was 70 months. So almost 2/3 of patients seem to respond in this analysis. And what about MDS with ring sideroblast? Is there a difference with regards to primary resistance to ESA in patients with ring sideroblast, whether without ring sideroblast? You see it's basically the same. However, predictive factors were the IPSSR and, as expected, also the median EPO level. This is for persisting response, this is for relapse, and this is for primary resistance. So again, demonstrating that EPO levels are important biomarkers of response to ESA treatment. And this is also the case for other treatment options like lenalidomide in non-del(5q) patients. You see the transfusion independence rate according to the endogenous EPO level prior to treatment. EPO less than 100, 42%, EPO more than 500, only 15%. So EPO level is a biomarker of maybe the ability of the residual hematoerythropoiesis or dysplastic erythropoiesis to be stimulated by exogenous means, or to improve maybe the microenvironment in the bone marrow. So how to make ESA better? Is there any opportunity? Well, communication. I think I showed you the differences with regards to response assessment. I think to assess the response for ESA treatment with regards to transfusion independence and hemoglobin increase is crucial, and therefore I think the recently published response criteria should be followed, especially in patients within the clinical trial. Other options, of course, may take advantage of combination treatments, and this is from a randomized study, lenalidomide versus lenalidomide ESA in patients with low-risk MDS failing ESA. So this was a combination study. You see that len had a response rate of 23, and which was almost doubled to 40%. However, median duration of response was quite comparable in both arms, and we know that len is not registered for non-del(5q) MDS, at least in the European Union. Other options and options which are used especially in the US is to give these patients HMA. So ESA failure patients given HMA single agent treatment. You see the response rate with regards to transfusion independence is 16% only, and it was not improved by the addition of ESA. So again, yes, some patients can be rescued with HMA treatment, but it's not very long lasting. First-line treatment with ESA, do mutations matter with regards to number? And you see that the response rate in first-line ESA treatment of lower-risk patients depends on the number of mutations. So the more mutations, the less the response, again highlighting that the number of mutations basically is associated with the disease state, or with the whether it's more an advanced lower risk MDS, and maybe these cannot be pushed, the progenitor cells cannot be pushed and mature better with the addition of exogenous EPO. Exogenous EPO is, of course, what we do also in patients with renal failure. traditionally. So what about improving endogenous Epo? And there is a drug in current clinical trials. It's roxadustat. It's a PHD2 inhibitor. And by modulating HIF-1 alpha, it increases endogenous Epo alpha, but it's also acting via anti-inflammatory means. And you see here a registration trial, roxadustat versus Epo alpha with regards to hemoglobin increase in patients with chronic kidney disease, significant improvement versus the Epo alpha. So this is proof of principle, and there is a current clinical trial ongoing in lower risk MDS patients. What about other approaches? This is a randomized study, 3 days of decitabine versus 3 days of Esa every 4 weeks in very early low-risk MDS patients. So this is basically first-line treatment with HMA. Only 19% were ESA pre-treated. You see median time from diagnosis was 5 weeks, so very, very early. And this is the hematological improvement, 18%, median duration of response 18 months. Well, you may say the glass is half full or half empty. I think the jury is still out which subgroup of patients may really benefit from this kind of treatment. This is an interesting study taken from the last recent EHA meeting, a placebo-controlled trial in low-risk MDS patients with being red blood cell transfusion dependent and thrombocytopenia. So a rare subgroup of patients, and they were randomized to oral azacitidine, CC486 versus placebo in a 2-to-1 manner. And you see the primary endpoint was met, 31% transfusion independence versus 11%. Also platelet response were seen, although they were not statistically significant here with regards to the overall percentage. So there was more severe neutropenia, of course, seen in the low-risk patient, and there were some early death rates in the CC486 arm. Therefore, the study was closed prematurely. However, the data look quite good, and again, this may be an appealing option if the drug will be developed further in this segment. Do we have other better approaches? Again, in MDS, a lot of targets have been detected, and also, of course, immunotherapy is an interesting one. I will just bring up some recent developments. This is a study initiated by the French MDS study group and now launched within the EMSCO network in Europe, also including our German MDS study group. It's IDH2 and IDH1 inhibitor trial in 3 cohorts of patients, including also low-risk patients with anemia resistant to ESA. So it may be appealing also to go for targeted therapy in these patients. This shows the TGF-beta pathway, which is a very complex network involving many ligands and is, of course, also very cell specific and quite complex. However, what we know from MDS is that it's aberrantly activated. So SMAD2, SMAD3 is phosphorylated, especially in progenitor cells in the bone marrow of MDS patient, and this leads to an altered erythroid differentiation. And this was the, let's say, the rationale to develop also drugs interfering with this pathway. Here you see other data demonstrating that SMAD7, which is the negative regulator of this pathway, is downregulated in MDS patients, and the effector is basically upregulated across all subgroups of MDS patients. So there are several, of course, ways to interfere with this pathway. Number one is you would go for the kinase inhibitors, which have been explored also in MDS and did not work quite well. Other options involve the trap of the ligands of this pathway, namely GDF8, activin A, GDF11, and the drug. There have been 2 drugs in development, so-called ligand traps. One is sotatercept, and the other one is luspatercept, which, at least from the early data, were quite suggestive to act primarily via an inhibition of GDF11, which is a natural occurring inhibitor of late-stage erythropoiesis. And by this way, by inhibiting GDF11, you basically take off the brake for erythroid maturation, and by doing so, differentiation and maturation is improving, and of course, red blood cells are produced and hemoglobin levels go up. This has been proven in an MDS mouse model. Left side, you see SMED2, SMED3 phosphorylation upregulated in the bone marrow of an MDS mouse. And by adding luspatercept, the acronym is REP536, this was downregulated here in the MDS mouse. And at the same time, actually, hemoglobin levels went up. Whether GDF11 is the target, I think, still has to be shown. There's some recent data showing that it may not be the target of luspatercept. However, it's a complex story, and I think we have to acknowledge that much more translational work has to be done in this situation. The first clinical trial was in low-risk MDS patients, was performed within the German MDS study group. And here you see patients with high transfusion burden, 10 units, 8 units, 6 units of red blood cells within 8 weeks, got transfusion independent by the single agent luspatercept treatment. And this were primarily patients failing previous ESA treatment. Also, the mutation analysis showed that SF31 mutated patients were preferentially among the responders. So the presence of ring sideroblastic phenotype / SF31 mutation was associated with a higher response rate compared to patients without this mutation. This led to the Medalist trial, which was published recently, and the trial actually commenced only in patients with less than 5% blasts and a ring sideroblastic phenotype and or an SF31 mutation. And you see IPSSR very low, intermediate risk, and prior ESA response so they had to be refractory or intolerant, or they could have been also ESA naive in case of EPO level of more than 200. 2-to-1 randomization. This is the primary endpoint. The study met actually also the primary endpoint. Significant improvement of red blood cell transfusion independence rate for 8 weeks. If you go for the new IWG classification, you see 19 versus 3.9%. And this is transfusion independence rate of 16 weeks, so longer duration. Now coming back to these 2 patient cases, just highlighting that both patients had anemia, transfusion-dependent anemia, being ESA responsive for a couple of months, but then losing response. And here you see SF31 mutation, this patient U2A1 mutation, but however, both are MDS-RS, so both have a ring sideroblastic phenotype and would be eligible for luspatercept now. However, you see that IPSSR may underestimate the prognosis of this patient because SF31 mutation has a very good prognosis, and maybe overestimate the prognosis of this patient because we know that these kind of mutations have a rather dismal prognosis and a high rate of disease progression in these patients. However, both are or could be eligible for luspatercept treatment. So the question also from the Medalist trial, 95% had an SF31 mutation, but do other mutations matter with regards to the response rate? You see the number of mutations at baseline and response. There was no significant difference between these patient subgroups. What about duration of response? You see 30.6 weeks versus 13.6 weeks, significant longer duration of response. And it's also important to say that there were also roughly 1/3 of the patients who had a second or even third event of transfusion independency, lasting sometimes for many months after they received another red blood cell transfusion after a long period of transfusion independence. So there may be also intervals, second or third intervals of transfusion independence if you continue luspatercept treatment. So this is the current reality. We hope that this would be the case, that both drugs, both continents, the drug would be licensed, and you see luspatercept now is approved for low-risk MDS with ring sideroblasts in the US, but also now in the European Union. And of course, in a patient failing Epo treatment, ESA treatment, now it's, I think, a new standard of care, second-line treatment for these patients. What about non-RS patients? Do they also respond second line to this luspatercept treatment? You see non-RS response rate 32.3 and transfusion independence 31.8. So yes, they also respond to the treatment, but to a lesser extent. However, there's an ongoing randomized study, the so-called COMMAND study, randomizing luspatercept versus Epo alpha in patients being naive to Epo treatment. So this is a head-to-head comparison in patients with either RS or non-RS phenotype and having received red blood cell unit transfusions. So also an earlier intervention in lower risk MDS patients. Are there other concepts? This is actually imetelstat. It's a telomerase inhibitor currently in phase 3 clinical trials. This is taken from the phase 2 study, 38 patients. You see a transfusion independence rate between 37 and 40%. And actually, there was no difference with regards to Epo level or the RS or non-RS phenotype. So an interesting drug given IV every 4 weeks. And there's a current ongoing phase 3 study. Novel targets may be the inflammatory processes being or seen in the MDS bone marrow of low-risk MDS patients. So anti-inflammatory drugs targeting several pathways and cellular subsets, which may include regulatory T cells, MDSCs, but also markers of inflammation like S100A or interleukin-1 beta. So the inflammasome activation is a current target of clinical research in lower risk MDS patients. And this is also shown here that several drugs are currently in development or in clinical trials targeting immune targets in MDS, including checkpoint inhibitors, but also bispecific antibodies, and also, of course, CAR T-cell treatment is an evolving field. What about high-risk MDS? Just touching base on that very briefly, I think in high-risk MDS, the first question is always, is this patient transplant eligible or transplant ineligible? For all these patients being non-eligible, HMA-based treatment is the standard of care. And in case of failure, I think we have not so much to offer. I will come to this in a second. Transplant eligible, of course, the question is how to get into transplant prior treatment, yes or no. But I think then transplant is the preferred therapy. But I think we need to be better, especially in these older patients where ESA versus transplant. I think transplant is better, but you see that only 1/3 of the patients may be cured, and also the mortality in older patients is still an issue. Just for the ESA, just to show you that, of course, ESA is better than conventional care regimen based on this registration trial, but I think ESA is still a bad player also with regards to long-term disease control. So HMA plus venetoclax is very active in AML patients. This is CR/CRi rate. You see more than 60% have a CR/CRi, and there's also currently an ongoing phase 1, phase 2 study exploring this combination in higher risk MDS patients. HMA failure there's a tremendous medical need, and the median survival is between 4 and 6 months. Of course, some patients can be rescued by transplant, very little subgroup of patients. So I think it's very important to offer a clinical trial in patients with HMA-based therapy. So this is actually the summary slide, just how to approach MDS patients in general. Of course, prognostic scoring systems are very important to say whether this patient has a good risk or low risk or a poor risk or high risk feature. I think if the patient is of good risk, then of course standard therapy, including supportive care or growth factors, are treatment options. In case of high risk, HMA or transplant may be considered. Performance status and comorbidities, of course, play a very important role, whether you can apply a standard of care in these patients. Epo level, as I showed before, is in biomarker for ESA success. Ferritin levels I didn't touch. Iron chelation therapy. But I think genetics become more and more important, also with regards to treatment decisions. And of course, this is not cytogenetics, but also molecular data come into play and may help to stratify a patient. Some of these molecular data may also be druggable targets. As of the UM mutation is of course not targeted by luspatercept, but luspatercept works much better in these patients. P53 mutation, I didn't touch base on this, but there are studies currently ongoing with P53 modulators. In wild type, P53 nucleins are actually currently given within clinical trials. IDH, IDH1, IDH2 I mentioned already, and also spliceosome mutations may be targeted with spliceosome modulators. So I stayed in time. Happy to take questions, and thanks for listening.
Thank you very much, Professor Platzbecker, for this comprehensive presentation. And yes, I encourage the audience to ask questions in the chat.
Yeah. Do you think any of the new agents will ever stop the need for transfusions? Yeah. Yeah, that's a good point. I mean, I think for low risk disease, luspatercept obviously does not stop it forever. I think nothing is forever in life, but many patients now with a longer follow-up are transfusion-free for years, some of these patients. So I think the future will be not, also in MDS, will not be single agent treatment, but maybe combination in order to improve the outcome. And of course, for the high-risk MDS, I would say that there are novel combination partners for azacitidine, looking also very, very appealing and very good data with regards to transfusion independence. So I think, yes, there is light on the horizon for these patients.
Thank you very much, Professor Platzbecker. Thank you for this discussion. Before we finish this webinar today, I have a few information as well. First of all, I would like to invite you to visit our EuroBloodNet Edu channel on YouTube, where all of the webinars will be published very soon. And of course, follow us on Twitter, LinkedIn, and Facebook. And please subscribe to our EuroBloodNet newsletter, where you can have all of the information on ongoing initiatives we are working on. And please join us for the next webinars. And I wish you all a nice summer break, and please stay safe. Thank you very much.
You too.
Bye-bye.
Bye-bye.